ασθενών που έχουν το πρόβλημα του γλαυκόματος και τη μεταμόσχευση. Ο Dr. Larkin θα μας καλύψει αυτό το θέμα. Please, Dr. Larkin, would you like to give your presentation? Thank you.
Thank you, Professor Kozaboulis, for asking me to join this symposium. I've been speaking at conferences on corneal transplantation for at least 15 years, and this is the first time I've ever come across a roundtable discussion or a symposium on glaucoma. And this is a very neglected topic, and I think it's very good that this is the theme of our discussion this morning. I've just got a very small number of slides. There will be some repetition of what you've heard from the preceding speakers, but I would say these have been really excellent presentations. This is a very large data set from the United Kingdom, showing the influence of glaucoma on survival of penetrating transplants. And this is a huge data set. You'll see that there are two survival curves going out to 3 years. The top one is non-glaucoma patients, over 6,000 patients. And the lower line is patients with glaucoma, nearly 2,000 patients. And you can see that from about 6 months following transplantation, around here, you can see that the two lines begin to diverge. So the glaucoma patients begin to lose their graft function well before 1 year after surgery, about 6 months. And I think this correlates with one of the papers that was discussed earlier. So this is a very large data set from our own country, published in the AJO 3 years ago. So the impact of glaucoma in at-risk patients is usually seen within 6 months, possibly corresponding with the duration of steroid treatment after surgery in these patients. The other point that we found was that a high proportion of grafts fail due to endothelial decompensation, a much higher proportion in glaucoma than in non-glaucoma patients, probably as you would expect. Now, the other point to make is that the failure rate it depends on glaucoma, but also on the indication for graft. So if a patient has glaucoma, that has a bad influence on transplant survival. But that also depends on the primary corneal disease for which the transplant was done. So as you have heard, keratoconus, for example, very low risk of problems with glaucoma. On the other hand, patients in whom the indication for graft is a primary endothelial disease, these patients are the ones. So this is Fuchs, and also particularly patients with pseudophakic corneal edema who have a graft for this indication. Now, what about the actual glaucoma management? Here also we see divergence of transplant survival according to the management of that patient's glaucoma after glaucoma diagnosis. So in this same data set, we've subdivided the glaucoma patients into those in whom treatment of the glaucoma is medical only, and you can see that that's nearly 2,000 transplants, 73% survival at 3 years post-transplant. On the other hand, patients in whom the primary management of glaucoma is surgery, and I should say this is surgery done at the time of transplant or surgery done post-transplant, for example, trabeculectomy or a glaucoma valve sometime after transplant to get control of pressure. And these patients have lower transplant survival. Does this mean that glaucoma patients after transplant should not have surgery? No. The point I'm making here is these patients probably have more advanced glaucoma, they have worse pressure control, and they have surgery for this reason. So these patients are a more difficult glaucoma group in which to maintain transplant survival. But there's no question about it, that it's best to control glaucoma before the transplant is done if this is at all possible. And this is what I always do in every patient. So these patients in my own hospital, where I'm privileged to have a glaucoma clinic right next to my own in Moorfields, on Monday morning I'll send those patients next door to my colleague, and they will have baseline glaucoma examination, they'll have trabeculectomy or, more likely, a glaucoma tube. They will later have a transplant under my care 2 or 4 months later when the pressure is controlled. So I think that's the important practice point. And the other point to make is that we have quite a long time ago stopped doing laser cycloablation for these graft patients in my own hospital because the results of the laser treatment, my glaucoma colleagues tell me, is too short term, and they're not happy with that modality of management. So it's useful for very short term pressure control, 3-6 months at the very most, but surgical management of glaucoma is the rule in these patients. So this is a summary of the UK data. So these are nationwide data that I've shown you, not specifically Moorfields. Glaucoma has a major impact on graft success. How much impact depends on the primary corneal disease. I've told you that keratoconus patients do very well. Glaucoma tends not to be an issue unless it's steroid-induced or unless they are severely atopic patients in whom glaucoma has been a management problem even prior to the transplant surgery. Worst results in those with pseudophakic corneal edema coming to transplantation. The grafts fail due to corneal endothelial decompensation, so we think that this is due to poor barrier function of the donor corneal endothelium in the setting of elevated intraocular pressure. The glaucoma management can have very significant benefit for the patient, even if this is a missed diagnosis or is a de novo diagnosis following corneal transplantation. And I can only say how important it is, bearing in mind the biomechanics talk, the second of the presentations this morning, to really try to get field and to try to get intraocular pressure measurements that are accurate in these patients. Pretty well all the data that I've shown you are written up in the AJO 3 years ago, and I commend this to you if you're interested in further information about this really difficult problem. Now, what about posterior lamellar keratoplasty? There was some reference to this in the last presentation. We've just looked at the 2-year national outcome of posterior lamellar keratoplasty in the UK. This is almost exclusively Decimase stripping endothelial keratoplasty. There is very, very little, just anecdotal, Decimase membrane endothelial keratoplasty in the UK at the moment, and very little indeed, none written up. So these are DSEC outcomes in the United Kingdom, and its analysis here, this is a multivariate analysis looking at independent risk factors for transplant failure with a very large number of transplants, around 3,000. What I want to show you is the line in red here at the bottom, which is glaucoma at the time of the DSEC operation. So in patients with a prior diagnosis of glaucoma, or high pressure at the time of surgery, you can see that whether it's Fuchs or whether the patient has pseudophakic corneal edema, this is, on multivariate analysis, a very strong risk factor for failure of the DSEC and failure of the transplant. So I think of DSEC as it doesn't spare the patient any of the problems caused by glaucoma in respect of transplant outcome. There is only one thing that's worse than glaucoma if you're a patient having a DSEC, only one. And this table gives you the answer, which is in an inexperienced center. So if you go to a surgery center which does not do a lot of DSEC surgery, you are almost doomed to failure compared to going to a center where there's a lot of surgery. It's interesting that surgeon experience is not significant on multivariate analysis, surgeon inexperience, I should say, but center experience and center inexperience, very, very important. But second to that is glaucoma. So the message is the same in DSEC as it is in PK. Glaucoma loses grafts, glaucoma loses vision, and the management of these patients has to be very aggressive from the moment that the glaucoma is picked up. Now, there's one point I would like to make, and I'm not sure whether the chairman would have liked me to address it, which is management of glaucoma at the time of surgery in patients having posterior lamellar keratoplasty. This is actually a real problem. So you have a patient who's got a functioning drainage bleb, as in the photograph here, or a patient who's got a glaucoma tube, as in the photograph here, and in whom you are doing a posterior lamellar transplant. Now, the problem is that, as you may know, in these patients, we need to have temporary high IOP, probably dangerously high in some of these patients with cup discs and vulnerable visual field. But we do need high IOP to maintain graft tamponade and to allow these transplants to stick. So I've always thought this is a really paradoxical and very difficult situation. So what are the options? Because if you've got a functioning glaucoma drainage bleb, and if you have a functioning glaucoma tube, it will be almost impossible to get high intraocular pressure by injecting air into the anterior chamber. So the two tricks are one which is not favored by my glaucoma colleagues, which is to put some viscous viscoelastic up the tube to temporarily close the tube. The problem with doing this is you will get temporary closure of the tube and you can get graft tamponade, but it does cause problems with the glaucoma, with the aqueous drainage thereafter. And several glaucoma drainage devices have been really badly ruined by corneal surgeons, ramming large amounts of Provisc up the tube at surgery. The second option is to temporarily close the tube, to put in a supermid suture at the time of surgery to narrow the lumen, or to try to... This is very difficult to do in practice when you're trying to do, with a closed chamber, trying to do a DSEC. But the important point to make, I think, is that whether you do none or both of these things, we still, for some reason, get pretty good graft attachment rates without getting high intraocular pressure, so that DSEC, generally speaking, does give good results in these patients, not as good as in glaucoma patients who have not had a bleb and have not had a tube operation, but the results, generally speaking, are very good. To sum up, glaucoma, a major influence on transplant survival in penetrating and in posterior lamellar transplants. The steroid responder patients are the real problem in my view. They're easily missed, but should be an easy diagnosis. You can always test that by putting steroid drops in the fellow eye. Consider glaucoma surgery for intraocular pressure control prior to transplant, so as a second prior operation. And the final point is early surgery for glaucoma if there's a diagnosis post-transplant. And with these comments, I'll conclude. Thank you.
Thank you very much, Dr. Larkin. Έχουμε μερικά λεπτά, ίσως δεν ξέρω αν υπάρχει κάποια ερώτηση από το κοινό. Εάν όχι, θα μου επιτρέψετε να κάνω έτσι μία περίληψη όσων ελέγχθησαν. Θεωρώ ότι το θέμα του γλαυκόματος ή της υπερτονίας σε ό,τι αφορά τις μεταμοσχεύσεις όποιας μορφής είναι εξαιρετικά σημαντικό, αλλά είναι και ταυτόχρονα εξαιρετικά υποτιμημένο, τουλάχιστον σε επίπεδο παρουσιάσεων. Το δεύτερο που ήθελα να πω είναι ότι υπάρχουν πάρα πολλές μεγάλες και εγγενείς δυσκολίες για να παρακολουθήσει κάποιος μετά το χειρουργείο της μεταμόσχευσης τον ασθενή που παρουσιάζει τις μεταβολές της πίεσης. Και αυτές συνίστανται στο ποιο τονόμετρο θα χρησιμοποιήσουν, ποιες παραμέτρους κανένας θα λάβει υπόψη για να διορθώσει την ενδοφθάλμια πίεση η οποία καταγράφεται, ούτως ώστε να προσεγγίσει περισσότερο την αληθινή. Τι θεραπεία θα δώσει τόσο για το θέμα της ίδιας της μεταμόσχευσης, για την αποφυγή της απόρριψης, όσο και για τον έλεγχο της ενδοφθάλμιας πίεσης, πόσο αποτελεσματικά μπορεί να είναι αυτά τα αντικλαυκοματικά τα φάρμακα σε μεταμοσχευμένους κερατοειδείς και τι γίνεται με το θέμα του χειρουργείου. Όλοι οι ομιλητές βέβαια συμφώνησαν ότι θα πρέπει να ρυθμίζουμε προηγουμένως χειρουργικά ίσως το θέμα της ενδοφθάλμιας πίεσης. Όλοι είμαστε σύμφωνοι γι' αυτό, αλλά ξέρετε πάρα πολύ καλά ότι εδώ και σε παρθένα μάτια, όταν χειρουργείς το γλαύκομα, έχεις συγκεκριμένα ποσοστά επιτυχία στο long term. Καταλαβαίνετε σε μάτια με υφιστάμενη παθολογία ότι το να έχεις την απόλυτη ρύθμιση δεν είναι και το πλέον σίγουρο που θα επιτύχεις. Συνεπώς, μετά το χειρουργείο και τη μεταμόσχευση, μπορείς να βρεθείς πάλι στον ίδιο παρανομαστή με το τι θεραπεία αντιυπερτονική θα πρέπει να δώσεις. Θα ήθελα να ευχαριστήσω πάρα πολύ όλους τους ομιλητές για τις γλαφυρές παρουσιάσεις τους και να ευχαριστήσω βέβαια και τον ξένο φιλοξενούμενό μας για την τιμή που μας έκανε. Dr. Larkin, I would like to thank you again for your excellent lecture, and I think that it was very important to see this topic under several views. So thank you again, and enjoy your stay here in Thessaloniki.